Good evening and welcome to Cancer Matters, the podcast where we unpack the realities of cancer, the treatments that save lives, and the systems that shape patient care. I'm Puvanraj Kanagraj and I'm the Associate Editor of Cancer Matters. And this special episode is brought to you by the National Cancer Society of Malaysia and KALSIS. Tonight, we are diving into an issue that's touching clinicians, patients, insurers, hospitals, and families across Malaysia. You may have heard the growing friction in health insurance approvals, delays in guarantee letters, unexpected denials, and the real impact these have on cancer outcomes. The recent CodeBlue reports have shown there's plenty of denials and there's plenty of friction happening in the ecosystem. There's the nationwide specialist survey, there's Liam's comments about loss-making medical portfolios and government's latest work on MHIT reforms. There's a lot of noise, a lot of pressure, and a lot at stake. Our aim tonight is to cut through that clearly, fairly, and constructively. We'll be looking at this from three essential perspectives: clinicians, an oncologist, and an innovator working on financial solutions for seniors. Our goal is simple: to understand what's happening, what can be done right now, and how we can build a stronger, more sustainable healthcare protection system for all Malaysians. Joining us tonight are three voices who stand at the front lines of this issue. I'm joined by Dr. Gunalan Palari Arumugam, consultant anesthesiologist and critical care physician, and a leading advocate for clinical autonomy and system reform. Joining him is Dr. Mastura Muhammad Yusuf, council member of the Academy of Medicine Malaysia and the College of Oncologists, well known for championing equitable drug access and co-payment solution. My final guest for tonight is Mr. Jonathan Teoh, founder and chief executive officer of KALSIS, here to share ground-level insights from implementing alternative healthcare financing models for seniors. So let's get straight into this. I'm not going to keep you waiting. My first question is for Dr. Gunalan. Welcome, Doctor.
Thank you, Puvan.
From your experience and your writings, we've had this issue brewing not just today. It's been years. Healthcare system has been facing this. Patients at the end of this facing consequences. Where is the line between legitimate utilization management and actual interference that compromises clinical judgment?
Okay, it's quite a complicated question, and to actually begin with, let me just put a framework in terms of where we are right now. I think the healthcare industry has evolved from what it used to be a solely cash-paying patients that come into the hospitals and paying out of pocket, to the introduction of health insurance, medical card, that has evolved over the last 20 to 30 years, right? So as and when the coverage and the awareness in terms of having the insurance products were coming into play, many more Malaysians were purchasing such products, and many more were actually able to access the private healthcare system in order for them to get treatment for anything ranging from non-cancer to oncology, complicated oncology work and stuff like that. So this has been something that has been evolving over a period of time. It could be about, I would say about 30 years or so that has happened. Where the pain point that we are feeling right now is basically as and when the explosion of technology, advancements in, say, cancer care, introduction of novel treatment therapies, immunotherapies and whatnot. So this has now caused a significant, I would say, increase in the amount of medication and the cost of providing such healthcare to the general public. And that is in a way borne by the insurers as well. So what they used to be providing coverage for, slowly they've realized over the last 5 to 10 years that it is no longer enough. And where it is actually now becoming a problem, it's when you actually have to make sure that the product they sell is also sustainable for the long term. You don't want to have a policy or insurance product that collapses under the weight of all these payments that is happening at the moment. Now, so when the industry cried out that the premiums are not enough and we need to escalate the payout, the premiums that are being paid by the patients, then there came a breaking point. How much is the premium that needs to be in place before the patients can actually afford such a product? And that disconnect started happening. And when that disconnect comes in, the next step is actually basically certain rules are put in place, certain terms and conditions are put in place to actually make sure that, look, when you are utilizing such a product, to make sure that it's only legitimately applying to the patients who actually claiming for such a medical expense in a way that is actually allowed by the policy. Now, that is where most of the time the friction happens, because at one end you have a payer whose promise is to be taking care of you. You have a doctor who is actually trying to treat a patient to the best of his knowledge based on what is the most current medical knowledge that he has. And these two have to meet in the middle. And right in the smack in the middle is the patient, who's actually dependent on these two parties to actually provide that healthcare that he needs. So this is where the conflict sometimes happens. And to be fair to the industry as well, I would say 80 to 90% of the claims are paid, okay, eventually, all right? But the eventually part of it is where it becomes a problem, because most of the time, this discussion that takes place between the payer and the doctors trying to advocate for their patients and trying to justify why certain treatments are necessary. And this is where sometimes the line of discussion becomes a bit blurred. And that is where the findings of the CodeBlue survey, where they had interviewed 800 doctors, and the 800 doctors probably would have spoken about the 1 out of 10 or 1 or 2 out of 10 cases that they had, where they had lots of problems, and even some may be completely outrightly declined, for which there is no recourse for the patient. And the patient now has to either go to a public hospital or pay out of pocket, and that's where the burden of the finances comes into.
Dr. Guna, I'm going to need you to elaborate more on that, but the report from CodeBlue have stated that 99% of 855 private specialists perceive insurers or TPA interference in clinical decisions. Now, my question is, how severe is this interference today?
Okay, so it really depends on first of all, number one, the patient that comes into the private hospital, right? When you come with a medical card, the assumption is because you have a medical card, everything is paid for. That is what the patients come in, right? But there is a bigger picture that happens behind the scenes. The doctor has to make sure that the patient actually comes in with a legitimate medical clinical condition that warrants admission and warrants surgical treatment. Now, the interference that is felt by the doctors is when the guarantee letter that we are applying for, there's a lot of questions that are being asked. For example, is this something that is acute? What is the presentation? And what is the diagnosis? Or what is your investigation plans and whatnot? So there is a reason why insurance companies are asking this, is basically for them to set some kind of reserve to make sure that, look, this is legitimate and the claim is actually something that is payable from their side. Whereas on the doctor's part of things, it's basically, look, I have a patient in front of me. I need to actually start my treatment, but I can't start my treatment until I get an approval. And most of the time, a lot of patients also don't want doctors to start anything because they want to make sure that, look, please make sure that I have my coverage confirmed, because before you want to start planning for surgery or planning for that, because they also don't want to be burdened by, say, for example, at the end of the day, a hefty bill, purely because the insurance does not cover them. So there's all this kind of factors that is interplay before we actually have an approval. And that approval sometimes can be quick, sometimes can be a few hours, sometimes can not even happen after 2 or 3 days as well. And that is where many of the doctors feel very frustrated. And that frustration was stemmed in that 800 plus doctors who gave that negative comments and input on that. But again, to be fair to the insurers as well, as majority of it can actually be ironed out, smoothened out over a period of discussions among the both parties. For example, if there are doubts or issues in terms of why certain medical treatment is offered to the patient, or why a certain patient cannot be done as daycare, has to be done as inpatient, if this discussion takes place in a cordial, respectful manner, and both sides understands the issues and why the doctors have decided as such, whereas why the insurer has decided as such, and it's just about meeting in the middle. But clinical care must not be compromised. That is our main aim at the end of the day.
Doctor, before I move into the consequences of the effect that the patients feel, obviously there's this impression that patients go to private hospital to sort of run away from the crowd, from the long waiting time. But when you come and tell me there's 2 to 3 days of turnaround time, as a layperson, what's the ideal turnaround time a doctor would want for the patient? If you're saying 2 hours is a good time, but for an insurer, they have to go through all these claims, and what's the ideal time for them to
Again, it depends on the acuteness of the situation. Like, for example, if I'm actually scheduled for an elective procedure, say 2 weeks down the line, and I have now time to actually apply for the insurance company to say that, look, I got a knee replacement. It needs to be done, say, next week. But in the meantime, I need to see the cardiologist to get all this assessment done, echocardiogram done, or whatnot. And if I can get everything organized, and I need an approval from the insurance company, that is okay. That actually can take a few days. It's okay with the doctors. But where, say, for example, a patient comes in on the doorstep of the emergency department with a heart attack, with a stroke, with a head injury, these are the things that sometimes we need instantaneous kind of answer. And usually, if we can get an answer within an hour, that'd be good. But therein lies the challenge, because some of these conditions may actually be something related to something pre-existing that the patient has. And when you talk about pre-existing, there's another big argument altogether. What is pre-existing, what is not pre-existing, and whatnot. So is it related to the guy's underlying diabetes or hypertension? So when you start going into those kind of arguments, the care doesn't start. I mean, it starts, but you can't go towards the definitive care. Now, for example, if you have a heart attack, of course, the initial treatment of morphine, oxygen, nitrates, aspirin, or whatnot, it's started by the doctors. But you need a definitive, say, angiogram or angioplasty. That has to be done in, say, we call it door to balloon time of 90 minutes or so. So within 90 minutes, I had to wheel you into the cath lab and get the thing done, so that if I were to put a stent in for a blocked artery, at least your myocardium is viable and you survive that heart attack. If it's beyond, say, a certain period of time, even I go in, the risk is higher for me to do the stent procedure, and you end up with a compromised heart. You may end up in ICU for a long period of time. So the cardiologists deal with those kind of fine lines. The neurologists and the neurosurgeons deal with those kind of timelines. So if they don't get a quick answer from the insurer, this is where the problem starts as well. And bear in mind the medical legal part of it. If you happen to delay because of the insurance issue, and outcome at the end of the day is poor for the patient, there is actually very little that the insurance companies will be blamed. But it's mainly the doctors who are in charge of it. And that's why we are actually struggling, because if we are implicated in a medical legal battle with the patient because of poor outcome, the first thing they'll ask is, why didn't you do something for me at that point in time? So again, the balance of trying to be in the patient's doing everything in the right best interest of the patient, and to make sure that financially they can also financially literate enough to understand that there's certain payments that have to be done if the insurance is not going to cover you and whatnot. Complex argument, especially at 1 a.m, when you're having to deal with this kind of things. The last thing the doctor wants to answer is actually all his incessant questions from the insurance companies. He just wants to get things done for them.
I just want to add something to what Dr. Gunalan said about planned admissions, right?
Yep.
Recently, we have this refusal to cover for planned procedures, which is on Monday.
Yeah.
So what they do, they say, you can't admit the patient on Sunday. But the anesthetists or the physicians, they have to see the patient the day before the procedure. Or even for us oncologists, when we admit patients for radioiodine therapy, which only happens on Monday and Thursday, because we only have these 2 days to admit patients for the 3 days procedure. And they say, no, you cannot admit on Sunday. They're refusing to give the GL on Sunday. But we can't admit the patient that morning.
Yeah. So these are the kind of battles that I think we have to have the conversation with the industry. Okay, you need to understand, because right now the assumption is that we are admitting on a Sunday so that we can charge more. Yeah. Because there's an after office hour charges kind of thing that kicks in if you were to admit on a Sunday. But there's a different reason for that, and that is not it's not motivated by finance. It's motivated by you preparing the patient the night before. It just happened to be Sunday is an off day lah. So Monday is the first working day. Like, for example, I have the same issue as well when we have a patient presenting for bypass surgery. So you are admitting the patient on Sunday morning so that the anesthetist can come in once he reviews it, he meets the family, speaks to the family members and show, okay, Sunday, 12 o'clock, you have to be fasting, but this is what the things that we watch out for and all those things. So that on Monday, when he's wheeled into the theatre, He's already prepared for it. So imagine if the patient is admitted on Monday at 8 o'clock for a surgery at 8:30. That is not ideal for a cardiac patient. So this happens for cardiothoracic surgery, neurosurgery, so this kind of thing. So again, that particular directive that was given by the insurance company is something that we are actually highlighted and questioned, and hopefully that we will actually be able to tell them the rationale on why we are doing certain things the way. And that conversation has to start taking.
So I will circle back on this again. But one thing that you spoke about, the battle between the doctor and the insurers or the industry. Dr. Mas, you've seen countless patients. You have obviously been in between this battle. So you have been one of the battling parties, I would say. But it's no longer just a two-way battle. It's a three-way now. You've got the patients who are also willing to go, they've paid the premiums and now they're questioning, why am I being stuck here in this position? Before I go into your experience as a doctor, obviously you know what your patients go through, and these delays that could alter outcomes, treatment plans, health outcomes, how is it impacting them from the very start and along the journey?
I guess, okay, the trajectory of cancer patients is long. Okay, so cancer is a disease that nobody wants. People fear cancer, nobody wants, but people take insurance because they want to be protected against cancers. They want to have that lifeline, as I said. Okay, only to be sometimes to feel frustrated when it's not so. So, for example, diagnosis, right? So we come a long way. So cancer diagnosis now is complex. So we are doing scans, we are doing, more detailed scans, we are doing molecular tests, because all this gives us the opportunity to make an informed decision about how best to treat the patient, because they are not treating like a herd of cows. They are different, they are different category, even in one cancer type, breast cancer or colon cancer, they are just treated differently because the outcome is just so different. So from the beginning, from diagnosis, where most of our insurance industry just do not acknowledge that. So they say, okay, investigation, we don't cover. This is investigation. Or this is, when it's actually it's a molecular test to characterize the cancer. Oh, this is genetic. this is hereditary. So they're not covering. So the patients are very frustrated because they paid the premium and they paid really high premium sometimes, only to be told that. Okay, so that's investigation. Then we go to treatment. So treatment, over the years, right, then there has been some restriction to the policy. There has been some changes like, okay, we've decided that we're not covering immunotherapy, for example. Your policy is actually outpatient. Outpatient pays this much, very little. Inpatient pays that much. And when we say to the insurance, look, this patient has advanced stage cancer, requires treatment, and then they say, oh, but the treatment is oral. That means the situation is not severe. So cancer is not severe to them, but to the patient is so severe. That is what they have been working their life to actually cover themselves for. But the insurance say, oh, because you're taking it at home, it's a medication that you take at home, then we don't cover. Okay. Then when we are treating the patient, right, now we are already treating the patient, some of the cancer treatment that is established by WHO, by all the 1,000 guidelines in the world, they don't cover radiotherapy. They don't cover. Radiotherapy is one of the major treatment for cancer. Major. So you have surgery, systemic treatment and radiotherapy. We don't cover because it's outpatient. But it's going for cure. We're giving it for cure. Like nasopharyngeal cancer, what Datuk Lee Chong Wei has. So that cancer, right? And he's cured, I believe. So we also want to cure as many patients with nasopharyngeal cancer as possible. But they're not covering, for example. So there are a lot of like differences in how terms and how policies, because not all of us are literate about cancer terms, so they feel cheated. But we at the ground, right, we are the ones who are facing the volcano. Okay, the volcano when this happened. But let me tell you one incident just 1 month ago. Okay, so my patient who's covered by a TPA. Okay, so she was supposed to have treatment for her thyroid cancer. Okay, so this is a high dose radioactive iodine sources that we give to her. She has to be in a specialized room. It's not a normal ward, but it's a specialized ward for 3 days before the radioiodine dose in her body comes down, and she's safe to be discharged, okay, to go home. So by the night that she's supposed to be admitted tomorrow for her treatment, the GL, the guarantee letter, was not issued yet. So the hospital called me and said, Dr. Mastura, the patient GL is not cleared yet. Can you write something? So I wrote at night, okay, on Sunday, okay. I wrote a letter on Sunday and I said, okay, this patient has to be admitted for 3 days, 2 nights because this is radioactive substance. This is the IAEA rules and regulation, da 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 da. Then they come to say, okay, get 1 day. The treatment is for 3 days, 2 nights. And the patient just refused to come. She said, I will not come until I get the GL. Okay, the radioactive substance is going to be delivered tomorrow. If nobody comes, it just go wasted like that. Because it's a radioactive substance. It decays over time. Okay, just wasted like that. Then I said, okay, I write another letter. But this one is like on the form, on the letter. So I just scribble that I said, I am being medically, I try to protect the public. I try to protect the health people by not allowing this patient to be discharged after 1 day because this is radiation protection. Do you know what happened after that? They gave me an outpatient GL. So is this a conversation that, what do I tell my patient? What do I tell my patient about this? How frustrating, not just for the patient, but for us doctors. So if she, a young lady, does not come the next day for the treatment is wasted. It will be another 3 months to get a date for her. And what will be the impact to her health? Because that is the only curable treatment for her after her surgery. There's no other treatment. There's no radiotherapy. There's no chemotherapy for this situation. But for the fact that they gave me an outpatient GL as a retaliation to my very correct
Detailed,
letter.
yeah.
I was not being what? Like, it's just a normal letter.
Yeah. So to add on to Mastura, it's basically that I think there is an acknowledgement among the doctors industry, insurance industry, that the breadth of knowledge, the width of knowledge that is there at a specialist level is not adequately in concordance and understood clearly by the claims examiners. And the claims examiners on the industry side, to be fair, they can't hire 100 specialists sitting and accessing the claims. Okay, to be fair, it is not cost effective or not possible. But where they can be better at is basically the communication. Now, if you have a situation like what Dr. Mastura said, it would be far better if you can just pick up the phone and speak to the doctor and say, look, doctor, why do you need the patient to be there for 3 days? So sometimes what is written may not be adequately understood by the person on the other end. And we are more than happy to actually have the conversation with our colleagues on the other side, because we say, look, if I am in the hospital, Dr. Mastura is in the hospital, even if she doesn't understand what I do, I don't understand what she do. Can you imagine the guys on the other end in front of the computer screen and looking at it without no direct patient contact and trying to figure out what's the plan, what's the outcome, or what's the narrative that is actually being told in the GL form that we are writing. So again, another discussion that is actually highlighted to the industry as well, that I think they've taken it up very positively to say that, look, acknowledge that there are weaknesses and deficiencies. We need to work on it. And it is not only their side. Both clinicians, societies and whatnot also have to make sure that they understand why we're doing it, so that there's clarity, so that this one example hopefully will not be repeated by 10 other different companies, because we're not dealing with one insurance company. We are dealing with sometimes 10 or 15 TPAs and whatnot, and everybody will sometimes ask the same question, and we end up repeating ourselves again and again.
Yeah. Even for Dr. Mastura, when you deal with this, and then you did say, it sort of feels as a checklist behind the phone. Like the claims officer takes up, and we wouldn't know if he's medically competent, or they're just referring to a checklist and saying, okay, you only fill up 9 out of 10, you're not going to get the 10, so I'm not going to approve your claims. This conversation of making sure there's a specialist there, and it's not just a 1 or 2 years thing. It's been there for decades, right? And obviously dialogues have been had. Do you see improvement over the years with these industry parties, or do you think, what's the solution? Do they need to keep an oncologist in-house and just go through everything? Because it's coming to a point where it's so severe, where interference are not just affecting your work and your treatment plan. Like you mentioned, there's the radiotherapies involved, and, things that go two ways. Is there really a solution for this where, going beyond a checklist?
I think, okay, for me, I hope that the insurance industry go to the guidelines, meaning to say that if they are able to see what is in the guidelines and go by, because if we are saying that this is the indicated procedure for this or indicated treatment for this patient based on guideline, they have to actually
Abide.
yeah, because guidelines are made to guide us how to manage a patient. So they can actually abide by that. Second is actually like what Dr. Guna said, talk to us. If we can come on Sunday to write that letter, just talk to us. So sometimes they are not on the ground to actually see. For example, like also another example, I have a patient that required TPN, total parenteral nutrition, because she has had 2 admissions prior to that for not able to eat because she has advanced cancer ovary, she has multi-level obstruction, and she cannot eat. And she was having what we consider as potential sepsis. So we had to admit her, give her antibiotics, give her TPN. And actually, it's not that I'm writing forms. I actually fill up the forms, but I also wrote a letter to say that this patient has this. This was a previous infection that she had, and she requires total parenteral nutrition, which is 16 hours. And therefore, this has to be inpatient. I actually put that, and this has to be inpatient. But she was made to stay, this sick lady, waiting for the GL. Until like when I saw her in clinic, she was not even admitted by about 2 a.m. because waiting for the GL. So deferment after deferment, so we answer. So like 2 deferments and we answer. But what if she dies while waiting? Because she has, like I said, she's not well. But because they are not there to know that she's not well, then, so what if, let's say, is a day that I was going somewhere or I was sick, nobody, like checks on whether the patient is already admitted or not, then something may happen to the patient. And who's liable? Us. And who's being us, the family members and all that. So the worst outcome that can happen to a cancer patient is death. And that's what all cancer patients want to avoid. And that's what all of them want to try not to experience by taking up insurance.
I see. Well, now, I suppose in this battle, they are not just meeting the insurance parties, they're not just meeting doctors, they're obviously coming to you as well, Jonathan. What could seem as a losing battle to them, you may then provide sort of an opportunity for them to just try and see if there's another way around this. You obviously work with patients as well, you are on the ground. What are you really seeing happening today?
I would say that what the doctors have really articulated, that there are coverage gaps, that you need the cash to get treated, and waiting for the cash to come can impact your well-being. But what we're also seeing is also post-surgery, where a lot of things that are needed and is prescribed as standard of care is not covered by insurance. And a lot of patients that we see come to us say, well, we expected the insurance to cover us for everything that has to do with medical beyond the hospital. So we had, interestingly, an insurance agent. She's 62 years old, and she had stage 1 breast cancer. She did her surgery and a radiotherapy, but what she discovered, even though she had a 1.5 million ringgit annual limit coverage that she took up just after MCO, so it's a pretty recent product. She was told by her own company that she worked for that a medication that she needed to to take on a daily basis to keep the cancer at bay is not covered. And also, because taking this can cause a reduction in bone density, the medication you need to counteract the reduction in bone density is also not covered. And what's quite concerning is that when the insurance agent came to us, she had told us quite clearly that she relies on, her income is irregular. And this is coming from insurance agent that gets commissions from the products they've sold in the past. And she knows that she doesn't have regular income. And as a result, bet the farm that she would buy this insurance product to make sure that everything else is covered. And she discovered it's not the case. And that to me was very striking when people who are in the system, who will also be processing claims, TPAs, know about this and buy such coverage to be very sure and find that they are also on the other side of the losing equation, that they don't have the money to cover the gaps. And that's what is very concerning, and that should be surfaced, that clearly that design and the delivery of healthcare protection is incomplete. And we need to, as KALSIS, for ourselves now, we're trying to help solve the gaps, but we can't do it alone. Insurance is a product that everybody needs to cover for large medical expenditure, and for expenditure that could last a lifetime.
Yeah.
That's where we're coming from, to see, okay, what else could be done to make sure that we have healthcare protection not only for today's seniors, but we will become seniors one day. We might one day have cancer, so we better have that in place, because like the insurance agent, we might need it too.
Yeah, correct.
I like the fact that you mentioned about supportive treatment, because what I find is that there's cherry picking of what they cover and what they don't cover now. So cancer patients, right, it's not it's like a standalone disease, So who gets cancer? Those who are older and they have other diseases, right? And cancer treatment is also like, you just don't take the pill and there's nothing happened to you. You have side effects. You have side effects. And with more advances, with more innovation, there are side effects that you never even thought last time. Like, I'm giving a drug for breast cancer. It can cause diabetes. It can cause lung interstitial disease, But the insurance, my patients are saying, doctor, the other day you referred me, let's say Dr Gunalan is an endocrinologist. I refer because of the patient, high sugar, or the patient developed hypercholesterolemia from their hormone treatment. This is not covered, doctor. I say, how come? Because it's due to your cancer and the cancer treatment. They said, no, they said this one is not related. So that's a big issue now. It's increasing. It's increasing, and supportive care. So supportive care is I think from the get-go, like physiotherapy, speech therapy. What else? Yeah, supportive care in not just cancer, but other cancers as well.
So the issue here is this, and on one end, the product is sold, you have 1.5 million in terms of coverage. So the assumption is when it's sold, the back of my mind, I think I have 1.5 million there. So whatever that I'm going to need, it's there.
Yes, and especially when in the past you've heard about how they couldn't afford a certain blockbuster drug because the annual limit was this low. Exactly.
Yeah. So little did they realize that there is things that are called the terms and conditions of the policy, the general exclusions and stuff like that. So I think, again, as treatments are advancing in cancer care, I think the underwriting language may also need to be re-looked into, because what potentially was applicable maybe 20 years ago may not be relevant in this day and age. Like, for example, actually a lot of us are actually having old products, old policies and whatnot, where the underwriting language is probably relevant in 10 years ago. But today, the advancement is so much that you can't apply those things anymore. So again, I think it needs to evolve. And that again is the role of us as doctors. We need to feed back to the industry that, look, hey, we're having this kind of scenarios. And it's really up to the industry to accept those kind of, it's not criticism, it's actually feedback that we are seeing this happening on the ground, and we are likely to see this happening over the next 2-3 years. So there's a need for you guys to also understand what we are seeing and adapt the wordings, adapt the terms of conditions so that at the end of the day, you still want to be fair to your policyholder. And to us, we just want to do what's right for the patient.
Yeah.
A patient, policyholder, somebody has to be fair to them, and we do everything right for the patient.
Because my patient told me, doctor, according to I think there's a rule in the US. I can't remember what is the rule, ACA or something. They said the rule says if you have this rule basically protects if you have cancer, you are likely to be covered.
Yeah.
But here in Malaysia, if you have cancer, you are likely not to be
Not-
covered.
okay.
It's like the other way around.
Right.
you
No,
know?
I mean, US itself, there's a big problem as well. I mean, I'm sure you all know UHI, United Healthcare and whatnot. The CEO got shot and whatnot. We don't want any of those things to come across here. But there, it's very much a private healthcare driven kind of a setup. So they are really, really dependent on insurance to get coverage and whatnot. Whereas here, we still have access to public healthcare. But unfortunately, if everybody were to go to public healthcare, the system will collapse as well. So this is where the people who can afford it have the product, they've invested in it so that at the end of the day, they do know that if they have a disease, they can fall back on that. And that is the promise that has been sold. I think that is what we need to make sure that it is kept.
Yeah, I agree with that. It's just that, just to be on as a devil's advocate here, our patients are being told, get your doctor to refer you to the government hospital. Get your doctor to lower down their fees. When it's not about doctors' fees at all. Our fees is just so low. But I have patients who actually told me that the insurance agent is telling them to do that. Like the insurance agent is actually telling them, look, the co-payment now is high. The more you utilize your insurance policy, the more that you're going to pay as a whole. It's going to increase. Get your doctor to refer you to the government hospital. But not everybody wants to go to a government hospital for many reasons that only they know. Yeah. So, but our patient, they can't sleep at night being told that.
So, doctor, obviously, to give a better picture to our audiences, right? When you take a 1.5 million coverage, and then it doesn't turn out the way you want it to be, what's the cost that goes into treating cancer today?
If you have breast cancer, I think because breast cancer is the most common cancer in Malaysia. So if you have early breast cancer, there are 3 types of early breast cancer. Okay, so you may be spending between 50,000 for the whole thing to about 200,000 for the whole thing if you have early breast cancer. But if you have advanced breast cancer and you may be taking pills that gives you life, but you'll be spending probably 3,000 per month. So if it gives you life for like 5 years, but yeah, so it's about that. But then again, we must look at it not just from the like just dollar to dollar kind of value, but also the value that your patient sees the treatment. So if they would like to live 3 years so that they can see their children graduating or get married or have children, whatever, right? I think it's our duty as a doctor to actually give it to them. And we would be so happy if we have companies that actually give our patients the rights that they deserve, because they paid the 1.5 million premium, right?
Jonathan, we spoke very briefly earlier before this, Singapore struggles with private insurance companies. And do you see the same scenario unfolding here? And what could Malaysia possibly learn from this?
It's a tricky situation because Singapore is very different in the sense that it subsidizes a vast part of healthcare. It started with 15 billion, say, in 2015. It's about 20 plus billion today. And by 2030, Health Minister said that it will be closer to 30 billion. But at all stages of the way, Singapore has planned for this to meet that fiscal responsibility. But notwithstanding, we also do see that in acute inpatient care, 90% of it is delivered from public health care. So public health care is exceptionally strong. And so as a result, we have what you call IP riders that sit above the MediShield, MediSafe systems that already insulate Singaporeans from a vast part of financial shocks. So if I were to be a patient admitted into a ward B or C ward, I'll just pay very little in terms of co-payments. But of course, if I were to go to a more expensive ward. I can choose my own doctor. I'll pay a lot more, or otherwise I can choose to go to private. But even then, also what we're seeing from the data is that a lot of Singaporeans are overpaying for their insurance premiums because they want peace of mind. So you cannot discount the human tendency that they just not on the price they were willing to pay for peace of mind. And it's in a way a contract that they have made with the insurer that this is what I paid for. I should have peace of mind so that I don't have to worry about bills. I'm not sleepless at night, as what Dr. Mastura said, but rather I can focus on healing. So when that covenant is not upheld, then you run into issues, and it's something that will compromise care, and it's something that the Singapore government has stepped in to make sure that that doesn't happen.
I think one of the challenges is basically this, that, I mean, again, I'm not siding anybody here, but at the end of the day, all these conversations are starting to actually take place a lot nowadays purely because of the loss ratios. The industry is trying to catch up with the inflation, and it's just too
difficult.
So why those days they used to be able to pay a bit more and a bit more, I wouldn't say lenient, but a little bit more kept to the contract, kept to what they promised, was different compared to what is happening now, because there seems to be like a catch-up happening right now. It's just like the horse is bolting out of the stable, and nobody has actually can control it. And that is where I think things like what the government is trying to do right now, the reset initiative by Bank Negara, DRG is one that has been spoken about. The MHIT basic product that is the government is looking into that. All those are things that are actually being put in place. I mean, I think we probably will see the fruits of those initiatives maybe 5-10 years from now. But while we get there, this particular thing that we're having right now is quite critical. And we need to actually tackle it head on, but in a way that is actually not coming to blowing each other in the face. It is basically a conversation that's difficult, but has to be done in a mutually respectful manner, because whatever's said and done, nobody's going to be winner or loser here. Everybody has to win-win. Somebody has to find the right balance to make sure that all the parties involved still live to fight another day.
Yes. And at the end of the day, it's the patient that counts at the end of at the center
Correct.
of everything that we do. But maybe to add another perspective, very neutral, would be that whoever designed the insurance had to look at what were the underwriting costs 20 years ago.
Yes.
And 20 years ago, we certainly did not have immunotherapy. We did not have targeted therapy, things that you could take orally compared to what was then standard care was chemotherapy. So everything was constructed then. I mean, certainly if I were, say, writing the MHIT today, I would be told off very quickly that why am I pricing for an imaginary drug that doesn't exist? It's in the future. I can only write for what I can see today. So that will always be a catch-up, unfortunately, to what is the pace of innovation is delivering drugs that could save or prolong lives, but comes at a significant cost.
Correct.
So that's something that the design has to take into account. Now, if you are looking to contain costs, then and you know that you still have to make sure that you balance your loss ratios, then it's likely that there might be a mechanism that allows for a larger co-payment that, the pool cannot cover you. It was not designed that way. I think you could be honest with that. But then say, okay, we can cover this, but the rest you to cover. I think that is a lot more better conversation that now brings in the patient, brings in clinicians, say, look, we only got this much. What else can we, how else can we make up the gap? And I think that's something that we can all look for solutions together, because then it focuses us on looking at solutions rather than finger pointing.
I agree with that, because I'm also an advocate for co-payment. I'd rather my patient pay a bit rather than they take on a treatment that does not benefit them or give them a poorer quality of life, because that's also something that I see. That means that if, let's say, there's a treatment A and B, right, and treatment A is basically paid by the company based on policy from 20 years ago, 20 years ago, and treatment B is not. But should the company say, okay, you can have treatment B, but with a co-payment scheme, that would be very good, because I do not want my patient to take the suboptimal treatment A, whatever it is.
So that's where I'm coming to the final part of our conversation, Doctor. You know, the survey by CodeBlue has also shown that insurers are increasingly denying coverage for a wide range of medicines. You brought this up as well, whether it's expensive biologics or very affordable generics, right? And there's also this conversation or reports showing that there's backdoor arguments where insurers are pushing doctors to only use generic versions of medication.
that's right.
You have long advocated for co-pay models and cancer drug funds, and there are patient access programs available as well. What is a fair co-pay structure for Malaysian families, especially the M40 who are also resorting to come to the private hospitals? They want faster treatment. That's the impression that they have, right? Faster treatment, shorter queues, no long waiting times, and they don't want to compromise quality of care as well. So what's a co-pay structure that you think is fair enough, and you think that insurance are able to actually adopt this as well?
Okay, I think you're all aware, if let's say I'm not sure about other discipline, but for cancer patients, if let's say a private hospital based patient is being referred to the government hospitals, and they have to actually pay the first class fee, right? So for example, if a drug is costing 2,000 at government hospital, they pay 500, right? 500. I think that's a good percentage, because if the government thinks this is a good sum for the M40 to pay, then that's also, I think, a good sum for the
I think
M40 to pay. In fact, it's even better because they get that kind of treatment.
the figure that has been floated around, again, there's something that we're not sure finally what's going to happen. It's basically anywhere between 500 to a max of 3,000 ringgit. That is what it is being spoken about. But again, it depends on I would say the kind of admission that you're looking at. If your appendicitis is going to cost you 20,000, we don't expect you to pay 3,000 ringgit. Like, it's going to be a percentage of what is there. And if your bill is going to be for a neurosurgical surgery, for example, is 100,000 ringgit, then your co-payment will probably be a bit more.
25% is good, right?
But I would say up to a maximum, because again, you see the B40 or the M40 that are also paying, their monthly income may not be sufficient enough. I mean, it could be the co-payment itself could be half their monthly salary. So you also don't want to have co-payment burdening the public as well. So again, the balance in terms of what there might be a low figure that is like what Mastura said, say around 500 ringgit, but it won't be a percentage up to that 20,000 or 30,000 ringgit. Maybe a maximum ceiling would be put in place. But what is the ceiling? I mean, that I think the government or the insurance.
So, Jonathan, I want your thoughts on this. Intentional planning and sustainable pricing. Can this be applied inside the insurance ecosystem?
I think we've alluded to it, and I mean, there's no reason why it cannot. Because I mean, when patients come to us, they go to the hospital, they present as cash-paying patients, and that's when we start seeing care becoming a lot more intentional amongst the clinicians and hospitals, because they know that the patient's money is their own hard-earned money. They're treating it like as though it's their own. So to be very, very careful with how you manage it, and try to then cut the treatment to what they have. But also at the same time, patient assistance programs become available. So therefore, you are seeing signs where it can stretch every ringgit, where everybody has a part to play, not only hospitals, clinicians, patients themselves, even pharma. They're all part of that holistic equation. So there's no reason why this cannot apply for insurance setting, especially when you know that a higher co-payment is required. So maybe it's 25% up to a certain limit. Who knows? I mean, that's a discussion for another day. But what's quite clear is that everyone knows that if we don't do anything, the patient is going to suffer. But so what we're trying to do is we each take a hit, as it were, for the benefit of the patient, and at least the patient can go home to their family and live a better life ahead.
The cancer drug fund is.
I think just to add on to the generic versus original kind of argument, I think at the end of the day, we doctors have to be in a position where we I think nowadays it's expected of doctors to actually provide that option. Okay, there is an original option which is from the makers of the drug, and there is a generic option available from these countries. The cost of generic may be potentially a third or half or whatever, but the bioequivalence is said to be almost equal, or so it is ultimately your call. Okay, you present that to the patient, and that decision making has to be a joint decision making. Say, for example, if your policy covers only for generic, I mean, it could be something like, or say they cover original medication, but up to a certain limit, and you want to stretch your dollar to the very end, and you are okay, accept the generics, then it's purely something that a discussion that can take place between the patient and the doctor. Again, I think I won't say all generics are bad, and I won't say that the original drugs are priced way a lot. Why it's priced that high is there's a lot of R&D that goes behind the drugs in itself. I think we also need to understand that pharmaceuticals are not charging it simply for the sake of charging and making money. Maybe out of 200 drugs that they develop, only one may be the best drug that can be good for the. But imagine the 199 drugs that is actually gone down the drain, and the research that takes into place to get those drugs in. So that conversation has to take place between the doctor and the patient as well, because we are actually looking at locally manufactured generics as well. So as when the production of the generics actually taking place and rapidly expanding as well, we also can't be kutoking them. I mean, it can't be insulting the generic to say that it is less or inferior to the original as well. So again, patients have to make the call.
We've obviously come to the end of our conversation, but before I let you guys go, 2026 is fast approaching. We are a month away. And I want to hear this from all three of you. Or what reform do you want to see in this particular situation that's happening in 2026? Maybe Dr. Gunai can.
Reform is a nice word. Now, one of the reform that I want to see personally is a more meaningful discussion towards national healthcare financing. Okay, that is one of the 4 pillars that we talked about in the white paper, the white paper on healthcare. And there are various other components of it, but to me, that is actually very critical, because if you have national healthcare financing come into play, then the pool of money that can be utilized to actually expand the reach of the public to access to medications, access to quality public healthcare system will be better. And by then, the government will be able to invest in more hospitals, maybe even specialized oncology centers across the country. Now we have only 1 or 2, one in KL and one in Kuching, Putrajaya is one, and Kuching is coming soon, don't know when. No, there's the R&D and the research that needs to take place for cancer care is actually a lot. And so just like how IGN is a model of heart center that is actually government has invested, and look at it now. I mean, it's world renowned kind of thing. So, and good doctors who stayed in the system, who actually developed the heart services and cardiothoracic services to where it is right now. So I think that is what we should aim for, by having a national healthcare financing that adds on, not only on top of the taxation that is actually happening right now, some kind of additional fund that goes towards that pool of money that will be able to get. And eventually, national healthcare fund doesn't mean that the private sector is going to be ostracized. There will still be a role to be played by the private sector, where patients can still make use of the insurance to actually utilize private healthcare as well. But the vast majority of the patients who still are at the moment are not able to access good quality healthcare because the private sector is so stretched. That would be the solution for them as well. But that conversation, I think, it's a politically difficult conversation as well. So let's see.
I think I will continue on from his vision, which I share. But I think maybe what I can actually hope for to add to his vision is the voice of the patient. I think we lack that in Malaysia. We don't have that strong voice of patient group that can make the policymakers change or listen. I think if we could have a reform, I mean, of course, it comes with education. It comes with literacy. Either we can get people who have financial literacy, we can get people who are literate in all areas that are important for this, and then get them to come together with us to actually pressure.
I suppose we need more cancer literacy as well now.
Of course, yeah, cancer literacy. So yeah.
And Jonathan?
Well, I'm very heartened to see that what's been planned by MOF and MOH is a step in the right direction with the base MHIT, which is meant to, interestingly, increase coverage from the 22 million Malaysians covered to 40 million. So that brings in an additional 6 million people into healthcare protection. That, if we could expand that pool, it makes healthcare financing a lot more sustainable, because the vision is to have a floor, as what Minister of Finance has said, then have another layer on top, mirroring what Singapore is doing, what Australia is doing, that covers for additional coverage. And that, in its own right, when coupled with DRG, coupled with Rakan KKM, we don't know what the form and function is going to be, leads to what is effectively more value-based healthcare in the future. So that's very exciting. But at least that will be something in the midterm. It's not going to be happening so quickly. So if you ask me what could happen in 2026, really is what Dr. Gunalan says, conversations, especially with physicians and TPAs, because it seems like they are on two sides of a very large wall, very high wall, that they're trying to figure out what each other is doing on the other side, but not knowing that sometimes the true intentions that's beyond what's filed in the medical report that they see, that they're just trying to save lives, that all these things that they could not have mentioned in there. And I think if we could just perhaps lower down the barriers, maybe reduce these barriers, that's a good conversation. And I think to the TPAs out there that are listening to this podcast, I think we just like to invite them to come on the show to share what they're seeing on their side, because at the end of the day, at least the physicians are guessing what they're thinking. But at the end of the day, I think they are also human. They are also Malaysians. They also have people that they care for, and also are seeing a lot of issues on that side which they cannot voice out. So hopefully,
and one day there will be patients.
Yeah, maybe there might be Dr. Master's patients. Hope not, but no, at this stage, please. But I'm just saying that we need more conversations, but in a safe space where, like I said, what we're trying to do is create solutions together. No finger pointing. Acknowledge that what has happened, but move forward. Yep.
Thank you everyone for joining us today. And to our audiences, I hope you understand better what's happening. These are conversations on what can be done right now, and most importantly, on how we can build a stronger, more sustainable healthcare protection system for all Malaysians. And thank you for tuning into Cancer Matters.